and a very warm welcome to today's program. Looking into the wide scope of services that the pharmacist needs to perform today, we bring to you SPEAR, Smart Pharmacist Education and Refresher, a series of webinars with one of the most prestigious associations, Indian Pharmaceutical Association. The topic of today's webinar is antimicrobial stewardship that will cover aspects on optimal selection, dosage, and duration of antimicrobial treatment. We have with us our esteemed guest, Dr. Ramesh Adepu. Most welcome, sir. He is Director cum Principal, Vikas College of Pharmaceutical Sciences, Suryapet, and past Vice President, Indian Pharmaceutical Association. I will now request Dr. Ramesh Adepu to start with the session, post which we will have a Q&A session. Over to you, sir.
Thank you, Dr. Gulshan. It's wonderful to be part with IPA and the Pfizer and the Spirant. So good evening, the fellow pharmacists and other healthcare professionals. Hearty thanks to Pfizer for initiating this kind of continuing education series and the Spirant as the CMA partner. Today, we are all going to focus on our learning and updating ourselves with antimicrobial stewardship. In this 40-minute presentation, I'd like to highlight on certain concepts like the definition and goals of the antimicrobial stewardship, the key steps in developing the antimicrobial stewardship program, strategies for effective implementation of ASP, the necessary techniques for successful implementation of ASP, the role of pharmacists in ASP, and assessing the efficacy of ASP, the ASP practices during the COVID-19. Friends, all of us know antibiotics have transformed the whole medical practice because once the lethal infections which used to cost the lives of the people have now become easily treatable because of the availability of various narrow spectrum and broad spectrum antibiotics. But the challenge lies here. The appropriate selection and the use of antimicrobial agents to curb the infections and to save the lives is very important in selecting them prudently. Otherwise, it's going to cause the biggest challenge. That is what we call it as the threat. The threat is the resistance. The resistance is where we are unable to treat the simplest infection, though we have wonderful arms in our armory, because the microbes have already developed the resistance to them. As a result of this, we are going to lose the patients. We are going to increase the treatment and increase length of stay in the hospital, and ultimately the overall healthcare expenditure is going to increase a lot. So what is the solution for this? The solution is antimicrobial stewardship. The antimicrobial stewardship program, a successful implementation, definitely makes the prudent utilization of antimicrobial agents. So that's where we can save the lives of the people and make the treatment more efficacious. I would like to begin with the definition. Of course, this is the disclaimer from the Pfizer, as this information is only for the public use and for the learning or updating the knowledge of the viewers of this program. Coming to the definition of the antimicrobial stewardship, it is nothing but the optimal selection, dosage, and duration of the antimicrobial agents in order to give the best clinical outcomes and eradicate the infection with the minimum toxicity and with the minimum impact on subsequent resistance. So this is what a lot of antimicrobial stewardship. Because all of us know, surprisingly, the global research data also says 30% of the antimicrobial agents are being misused, abused. As a result, it is causing so much damage. Then who is going to control this? It is once again an authority which can devised within the hospital as a system and prevent the misuse of the antibiotics in the broader interest of the health of the patients. That's where the antimicrobial stewardship goals lies, because it is for the people, it is for the patient. So in the form of the better patient care, selection of antimicrobial agents is most important task. So right antimicrobial agent with the right dose. It's not only that, often what happens, a person comes to the hospital with an infection or suspicion of infection and do not know what type of infection it is, what pathogen it is. So until you have to depend upon the culture sensitivity report, it's not that we cannot give the antimicrobial agent coverage to the patient. So obviously, we prophylactically treat the patient. When we start the medication, once we get the results from the lab, then we can de-escalate according to the pathogen and according to infection, and therapy can be directed. And more important is right length of the therapy, because often antimicrobial agents are being used in the rural parts, say 3 to 4 days, 5 days sometimes. In 3 days, the manifestations may come down, but the pathogen cannot be completely eradicated. So in order to eradicate the pathogen completely, the full course of antimicrobial agents are to be given. So that's what is the right duration of the therapy. Coming to the goals of antimicrobial stewardship, the important goal is to prevent antimicrobial overuse, misuse, and abuse in both the hospital as well as in the outpatient settings. This is a common practice where physicians use them very, it is kind of abused depending upon the need, depending upon the marketing pressure. Sometimes antibiotics are misused. This is what even I have personally observed in my hospital. So it's very, very important maintaining the patient on a regimen to which the organism, which is more susceptible. So there you can control the infection very prudently. So that's where the whole antimicrobial stewardship program goes upon, to minimize the development of resistance to the pathogens. Then patients are exposed to antibiotics are at higher risk of becoming infected by the resistant organisms. An example is gram-negative resistance carbapenems and cephalosporins. They increase 10 to 20-fold with the broad-spectrum antimicrobial agents. So instead of using a broad-spectrum antimicrobial agent, based on the culture sensitivity report, selecting the appropriate narrow-spectrum antimicrobial agent, that is the best answer. That is the way easily we can cure the infection in the patients. What are the key steps in developing the antimicrobial stewardship program? The key steps, it is very important. It can be in the organization or in a healthcare setting. Motivation to improve the clinical outcomes for patients with the infections, prevent avoidable harm-causing antimicrobial prescribing, recognition of the potential and actual impact of antimicrobial resistance. How do we can achieve this? This is easily can be achieved by analyzing or conducting a drug utilization evaluation of antimicrobial agents, and also correlating with the pathogens which are present within that healthcare setting, and based on how frequently these antimicrobial agents are being used, how misuse is happening. Based on that, you can curb that kind of the practice, and you can rationalize the therapy and help the patients. So that you can achieve by having your own hospital antibiotic stewardship program. What are the important core elements of having this hospital antibiotic stewardship program? Very important thing is commitment from the leadership, because the hospital administration, unless they have the commitment to minimize the resistance, then they have to spare all kinds of the resources, whether it is human resources or financial resources or information technology resources, they can be spared. And the leadership should identify an individual, either maybe a physician or a pharmacist, as a leader who can accountable for conducting the program and making the program more successful. Another important step is having an expert in the pharmacotherapy. That is what I always feel, having a clinical pharmacist in the hospital, especially in treating the infectious diseases, where these kind of the clinical pharmacists, they are not just like the other pharmacists. They are a little different, because other pharmacists maybe come from with a background of the diploma in pharmacy or bachelor's in pharmacy, whose knowledge and training focuses more upon the procurement, stocking, drug dispensing, distribution. This kind of the activities will be there. Whereas the clinical pharmacists, they come with a qualification of Doctor of Pharmacy, which is 6 years, where they learn in depth about the pharmacotherapy, especially essentials of antimicrobials and their utilization in various kinds of the infectious situations. So they're based on their evidence, the antimicrobial usage can happen. So that's where the usefulness of the pharmacist comes in the best interest of the patients. And whatever the activities which are planned, that has to be implemented, and tracking all the events associated with the antimicrobial usage, like such as drug-drug interactions or maybe adverse events, so that can be tracked and motivate the patients, especially for the adherence. Or sometimes you may have to initiate the new antimicrobial agent, or going with the de-escalation of previous antimicrobial agent. Then any adverse events are there, immediately should be reported to the suitable antimicrobial like stewardship program committee, or to the adverse drug reaction monitoring reporting system. Then you have to completely inform this information to both the doctors, nurses, and other relevant staff, educating the clinicians about the disease or disease state management, resistance, and optimal prescribing. These kind of the informations are very essential when having the hospital antibiotic stewardship program. The ASP committee, it is very, very, very important. It is a fundamental in implementing the stewardship program. This committee provides or offers the strategic direction, guidance, manpower, intelligence resource for any stewardship activity. This committee can be a standalone group, or maybe in the subcommittee, or a part of the larger group. In case if it is a standalone, it should be integrated into the organization's the governing structure, because accountability is very important in successful implementation of the antimicrobial stewardship program. So that's where the stewardship committee, it should be very strong, and with a notion to implement whatever the directions they have planned out, and thereby the resistance of antimicrobial agents can be avoided. This is the structure of antimicrobial stewardship committee. This committee, as the core committee over there, they will be under the influence of medical director, chief executive officer, infection control manager. And of course, this committee comes out with the guidelines, and these guidelines will be passed on to the prescriber. The core committee includes a medical microbiologist, infectious disease physician, antibiotic pharmacist, infection control nurse, consultant physician and consultant surgeon, nurse or a resident, that is junior doctor representative, and finally, based on the collection of the data, to analyze the data, it is always prudent to have a data analyst with a lot of IT skills. What are the strategies for effective antimicrobial stewardship program. Looking at the strategies, first strategy is pre-prescription authorization. Pre-prescription authorization is essential so that you know unwanted use of the antimicrobial agents which are happening in the hospital or even in the wards. So you will be knowing the overuse or misuse. This can be easily tracked by conducting a drug regulation review, DUR. Like it's one of the methods of the pharmacoepidemiological surveys. So one can have a clarity what type of antimicrobials are being used by the different consultants on the similar kinds of the infectious situations or the pathogens. So based on that, one can understand how effectively these antimicrobial agents are being used. And it's very important to understand the spectrum of the activity of these antimicrobial agents. Like, are they narrow spectrum or broad spectrum, or conducting the culture sensitivity report for which antimicrobial agents they are sensitive. Based on that, we can definitely decide the antimicrobial agent. And more important is the toxicity. Along with the toxicity, it's very essential to consider the cost of the antimicrobial treatment. In developed part of the world, it's very, very essential because the auditing of the prescriptions are carried out there. So again is the treatment protocols, whether any agent is being prescribed, any medication is being unwantedly misused, or high cost treatment is being done, the prescriber has to be answerable to the auditing. And cost is very, very essential because often the healthcare is completely funded by those governments. It's not like, unlike in India, where 80% to 100% it is the healthcare cost is generally borne by the patient. Of course, now thanks to the third parties, so to some extent that burden is being reduced. Otherwise, once again, coming to the general public, the cost is generally it is levied on the patients. So that's where the pre-prescription authorization comes into the play. So you have to select, you have to identify the right antimicrobial agent and understand its toxicity, whether it is renally clearing or hepatically clearing, and by any chance is it going to cause harm to the kidneys, and then what is its cost. So based on that, better antimicrobial agents can be selected. Next step is the post-prescription review with the feedback. So always have the external reviews by a third party or an external agent or an external expert, who can understand the complete prescription review, or sample review can be done, and they can identify what kind of the antibiotics are being used in the hospital, whether they are properly being used or misused, abused. Instead of having our own review by our own people, there may be a chance of bias. So in order to avoid these chances of the bias, better to go for an external review. Because these reviews and feedbacks, when they are given by another person, definitely our treatment will become more rationalized and regularized. So that is an advantage. Another important step is to develop the policies to optimize the antimicrobial use. In order to develop the policies, better to have the documentations. Based on the data, we can develop the policies. So that's why always document every antimicrobial agent usage, especially its dose, duration, and what indication for it is being used. So then we know how unnecessarily drugs are being used, that we can identify. Develop hospital-specific treatment guidelines, because the treatment guidelines are generally the position statements. Position statements, they are the expertized opinions which are given out by the common consensus by the experts, and these consensus are in the larger interests. So obviously, when these position statements are available, which are for the larger interests, but when it comes to the local needs, like in a hospital requirements, the Pathogen spread, we don't know. So based on the pathogen spread and intensity, we can select our own, or we can come out with our own treatment guidelines. That is as institutional treatment protocols. So when you have that institutional treatment protocols, obviously all the clinicians are aware that these kinds of the pathogens are very common in the hospital. So this is the way the treatment has to happen based on the clinical manifestations, and then how to de-escalate or how to add on the antimicrobial therapy. All those things are explained in the guidelines. So that is an advantage. And more important is having the drug formulary. There is a hospital formulary. So in the hospital formulary, based on the committee's recommendation, only few antimicrobial agents are being identified and made available. So that is where you can avoid misusing of higher antibiotics. So that is the advantage of having the individual hospital drug formulary. Sometimes, though the medications are being used as a kind of empirical therapy, immediately after getting the reports from the laboratory within 28 to 48 hours, so you can assess the antimicrobial agents are being properly used or not. We can get the clarity within a day. If the antimicrobial agent is a suitable antimicrobial agent, the manifestations will come down, especially fever, it will come down. And the severity of the infection, that also will be slowly coming down. So these kind of the experiences will give the idea to de-escalate, discontinue, or tailor therapy based on the information which is given by the patients or the lab. So every time, assess every 48 hours, assess the need for the antimicrobial agent, or sometime to start the newer antimicrobial agent in case if it is not showing the response what it is anticipated. Definitely that can be done. Another important step is pharmacy-driven interventions. I was talking to you about the pharmacist's role. As a clinical pharmacist, they will have the clarity about the drug dosing, especially in case of renal and hepatic challenges. And they also have the clarity about the drug bioavailability ratios. So because sometimes, the patient has to be switched from the IV to oral. So what is the bioavailability ratio it is needed, and what kind of the dose it should be given. So that is the clarity the clinical pharmacist will be having. And based on the creatinine clearance or the Glover or filtration rate, dose adjustment can be easily calculated. Accordingly, the drug dose can be brought from the BA to OD dose, or from the TAD 1/3 of the dose. That depends upon the creatinine clearance that can be calculated. And another important is pharmacokinetic parameters and dynamic parameters can be assessed in order for adjusting the selected drugs. And antimicrobial dose optimization to maximize the penetration of the drug concentration to the organs or at the body tissue site. Thereby, the more the plasma concentration of the antimicrobial agent, which is at the site or the tissue site, then the pathogens can be easily cleared off. And alerts for common situation where antimicrobial therapy may be inappropriate or unnecessary. Sometimes oral pharyngitis. Still, clinicians use antimicrobial agents, which can be easily controlled using an antiseptic oral wash. Yeah, you can just control it. So instead of going for antimicrobial agent, using such kind of the strategies, including saltwater gargling, can also control it. So unnecessary usage can be avoided if a person explains the concept very clearly. Coming to the techniques of the ASP program, having our own formulary. Like formulary, it is the hospital-based formulary where the formulary committee develops, identifies the antimicrobial agents to be used within that hospital system. But sometimes the situation is, in case if the patient who got treated in other hospital and maybe shifted to this hospital, there is always a bias. The clinician in the previous hospital might expected that this kind of higher antibiotic is essential, but when the patient is shifted to this hospital, there is a committee, there is a formulary, there is a ASP program is happening. Then the whole lot should be shifted to the ASP, because the decision must be taken by the ASP, and the decision should be implemented. It's not the question of any obligation of the clinician that my molecule has to be continued. That's not like that. It is very essential that patient should be completely cured. Patient should be freed from the infection. That is what is the ultimate goal. In that situation, the committee, whatever, or as per the ASP program of that hospital, whatever the guidelines it is to be followed, the same guidelines need to be followed, and the continuation of the antimicrobial agent all depends upon the ASP consultant. Sometimes another important tool in the stewardship program is the treatment order sets. Order sets, once it is given, surgical prophylaxis order forms to improve the antibiotic choices, generally based upon the individual patient, like for example, age, based upon the height, body weight, or body surface area. Those can be calculated. So always to have some algorithms or the pocket guidelines which are developed by the hospital, or otherwise it's also the position statements they come out within the pocket guidelines that can be utilized in order to come out with the proper treatment for the infections, especially for the common infections, and especially for the younger doctors who wants to improvise to be as a excellent physicians. These algorithms are highly like a ready reckoner tools which can be used to treat the clinical conditions. Clinical guidelines, it's always, once again, the road path to treating the clinical situations. But these clinical guidelines are often developed by the professional associations, because professional associations, it's not that association will develop. They form a consensus committee who are expertised in treating, who has a complete clarity about the infection, and who has complete clarity about the medication usage process. Such kind of group will be working on coming out with these guidelines, and these guidelines will help all the frontline professionals who are not specialists in the infectious disease treatment. So in that way, the antimicrobial treatment can be easily done. Pharmacodynamic dose optimization. One stewardship technique that is being used with increasing frequency is pharmacodynamic dose optimization. It's based on how much amount of the plasma concentration of the drug to be made available so that it can kill the pathogen. So that is what is the pharmacodynamic dose optimization. Like for example, some IV formulations like piperacillin, tazobactam, meropenem, doripenem, which needs to be infused. These drugs need to be infused for a longer duration so that the peak plasma concentration, the same straight line can be maintained if you take the graph. Because at initial stages, the dose will be 0. Slowly, as the time slot increases, the concentration reach to the minimum inhibitory concentration. That is where, inhibitory concentration, that is to kill the pathogen. So then once it reaches to there, it has to be maintained sustainably so that the killing of the pathogens continue, so that the infection rate will come down. So it can be either prolonged infusion or a continuous infusion, or it is maintaining the trough levels. So these are all the strategies which comes under the pharmacodynamic dose optimization. Pharmacy dosing programs, as already mentioned, pharmacists are responsible for the dosing and monitoring of whether it is vancomycin or aminoglycosides in some hospitals. I used to do this kind of the activity. because as aminoglycosides, they have the renal challenges, especially patients with the renal challenge. Then the dosing need to be adjusted very clearly. And according to the glomerular filtration rate, we used to apply the Cockcroft-Gault formula and calculate the GFR. And based on the GFR, whether the half the concentration of the dose to be given or 1/3 or the quarter dose. So accordingly, we used to calculate and we used to advise the clinician so that the clinician can give the prescription, nurse can implement the same. Often using the electronic dose calculators, pharmacists are able to choose the initial doses and adjust the dose being on the levels with more accuracy. This is very much possible. And now we have certain kind of the algorithms are available, those calculators are available. We can easily calculate it. Once even software is available. So what you call these softwares are as the clinical decision support systems. So these support systems, the moment you give the input of the patient information, the age, body weight, height, and the lab parameters and the drug, automatically it says, this is based on the lab parameter, your creatinine clearance is high, so better not to give this dose. It is the dose to be given. So automatically the drug dosing can be calculated. And those hospitals without, this is a wonderful information in the interest of the pharmacists, because always pharmacists are looked at, they are only confined to the procurement, stocking, dispensing and distribution. In overseas, their role is as equivalent as a clinician. Clinician focus more on the diagnosis, whereas the pharmacist focus more on the treatment part. They complement the treatment given by the prescribers. They rationalize the therapy. Rationalization of the therapy, it is once again based on the evidences which are published in the literature. So that is the most important contribution which the pharmacists are giving. As a result of that, there are so many findings are there where they say that those hospitals without the pharmacist managed protocols, they have a higher reporting of mortality, patients staying long time in the hospital, more adverse events. Obviously, there is a very clear-cut data which is available. 1 day by increase, there is every chance of having 10% increase in the adverse drug reaction chances. And as the patient stays in the hospital, no hospitals gives free of cost treatment. Obviously, the charges will increase. That is, hospital charges goes up. So it's going to be a burden for the patient. So in that way, presence of pharmacists automatically is going to be highly valuable, especially in these kind of the special situations. And even in Indian scenario, the NEABH and JCI, they are mandating having a pharmacist in this kind of the scenarios. The interventions for this antimicrobial stewardship program, like interventions implemented, should be reflect both on the needs and the resources of the organizations. So the organization, if they have a clear-cut policy, they are implementing the NABH or standards they are maintaining, obviously they have to have this antimicrobial stewardship program. And they have to allocate the proper resources for this successful implementation of the program, because the outcomes are highly useful not only for the organization, including the patients. If the patient satisfaction is very high, the organization growth is going to be very high. So the successful implementation of the core interventions are done, then they can go adding on more additional interventions as and when, as appropriate, the organization feels and decides it can be done. Like core AMS program interventions includes formulary restriction with reauthorization of named anti-infectives, prospective audit with intervention and feedback. This should be a prospective. Generally, a retrospective and prospective, that is called as an ambispective. Even that kind of the evaluations also adds a lot of value in successful implementation of the ASP. Multidisciplinary AMS team and development of the therapeutic guidelines. This will be the core interventions which can be mandatory to be done, followed by based on the necessity, based on the comfort of the organization. They can add on the additional interventions such as de-escalation of therapy based on culture sensitivity reports, optimizing the drug dosing based on the renal or hepatic challenges, switching from the intravenous to the peroral, and educating their own healthcare professionals and educating them on the antimicrobial order forms, antimicrobial cycling, combination of antimicrobial therapy, information technology to provide the decision support and enhanced surveillance, having the antibiograms at patient and organization level. These are all the additional interventions based on the situation they can do. Coming to the assessment of once the stewardship program, antimicrobial stewardship program is implemented, using the various indicators like local indicators, you can assess how successful the ASP which is happening in the hospital, like assessing the capacity, systems and processes in the organization, whether they have it or they are being properly being used, and how much is the outcome. So based on using the process measures and indicators, they can even identify the outcomes of the proper utilization of the antibiotics, especially prescribing and the clinical outcomes. So these kind of the measures can be assessed. Then structural measures, having the national and healthcare facility core elements can be used as a checklist. So this is the checklist can be prepared by the hospital for assessing the structures of national and healthcare facility AMS programs. The outcome measures, like an essential part of the any AMS program, whether it is national or facility, but especially within the organization in order to study the antibiotic prescribing or over time use. Coming to beginning the assessing the AMS programs, the using the recommended to ensure the implemented interventions which are not having the unintended consequences on the patients when the antibiotics are being used, like such as ADRs, often used as a proxy measure to improve that the antibiotic prescribing practices are moving in the right direction. So if you have the guidelines, and these guidelines are being developed and being implemented and conducting once again the review program, then one can understand whether the antibiotic what you have been selected for particular pathogen then is the same is being used or not, whether the antibiotic utilization is in the right direction. That can be analyzed easily. Most important thing in success of the antimicrobial stewardship program is the education and training. For every professional, whatever they learn in their school, it is limited. As the science is advancing, as the knowledge is increasing, obviously the clinical challenges from time to time, day to day varies. So always poses challenge to the professional. So to keep abreast with the latest changes in the interest of the patient care, education and training is obviously it helps a lot to the professional, which can be done as a pre and in service training. Like when you are in the school, you have a lot of curricula, you have your own curricula, you have textbooks, you have journals, and you will be conducting the seminars, you will be conducting the case reviews, probably sometimes case dissection, and a lot of journal club dissections. This gives us an idea, knowledge, so that how to treat a clinical condition will have a clarity. Then workshops, honestly, they play a key role in improvising the competencies, because that is a clinical situation. Probably the situation is given to different teams, and which team performs, where in the team 2 to 3 professionals are being put together. So how much you are really understanding, how much you are contributing in the dissection, how much you are coming out with the outcome, there your knowledge definitely being like an appreciated one side. Other side, if you do not have that, definitely you will get clarity. You learn a lot. Whatever the doubts you have, definitely you will have a clarity. And of course, that is what you call as one-to-one learning. One is in service at the time of learning in the school, that what you learn, and in the workshops as one-to-one learning. Of course, now post-COVID situation is a hybrid learning. In hybrid learning, sometimes you can go to the classroom learning or even online. Now, what we are having, it's an online learning. So in that way, we can update our knowledge, our skills, competencies. Because sometimes, people, sometimes even video recorded webinars will be there. At your pace, you can listen to them, understand them. If you have some clarifications need to be done, generally in the webinars, the presenter may give their email ID. You can post the questions. Definitely, the answers can be sought from them. Then practical training at the centers of excellence, especially AMS teams and AMS champions, they need to gain additional knowledge, especially practical hands-on training, which can be possible only at the centers of excellence. Better to go there, spend some time, understand how they are treating the clinical situations. Yeah, that will definitely you will learn a lot and will add on value back to the institution. While at the job, that is on-the-job learning. A common approach to successful training make use of both existing structures and opportunities that arise in the clinical environment. It's a day-to-day based learning. For a professional, every moment is a learning opportunity. Unless we consider in that way, we really cannot progress in the profession. So every moment is a learning opportunity, whether it is a challenging situation, whether it's a funny situation, or it is whatever it is, it is going to give an opportunity to update ourselves. So in that way, on-job training, these are all the opportunities for the education and training. You can see various training delivery modes for updating ourselves and fitting ourselves into the antimicrobial stewardship program. We all have experienced this COVID-19. We have seen the very bad side of the COVID-19. Billions of people got infected. Millions of people died because of the virus. And once again, the viral infection followed with the microbial flora, then you have to have proper utilization of the antimicrobial agents. So there, once again, having the stewardship program, definitely it is useful. Definitely it is mandatory, because you cannot just rule out the COVID-19 impact. So obviously, having the multiple challenges of viral and bacterial infections, how to treat. So they're creating the treatment guidelines, assessing the antimicrobial overuse. This was found out in many hospitals. Unnecessary use, misuse, abuse, it has happened. So if we have the guidelines, definitely you can control the abuse of these, misuse of the antimicrobial agents, monitoring and managing the drug shortages, because it's a load on everybody. Every patient wants to survive. Obviously the production of the antimicrobial agents may not be there, so you have to procure them, keep the stock, and distribute to the patients. Obviously, if you have the antimicrobial stewardship program in place, then you can prioritize which patients need to be given antimicrobials, which patients don't require. Then you can adjust the stocks, which you can use them for the patient usage. The COVID-19 could lead to the increased antimicrobial prescribing and thus increased resistance. That is also biggest challenge we have faced. This kind of a challenge was happened. And resources required to face the COVID-19 pandemic could delay expansion of the antimicrobial stewardship program. Of course, in case of the low and middle income countries, include drug formulary management to ensure that enough stock of the antimicrobial agents are maintained in the pharmacy, and proper prescription for the antimicrobials are initiated, and supply of the antimicrobials only to the patients which is being prescribed, and that to be dispensed to them. So in that way, definitely antimicrobial stewardship program, it is going to help in misuse of the antimicrobial agents. This can happen only through limiting unnecessary antimicrobials, then create your own hospital treatment guidelines, give a prior authorization, whether it is needed or not, based on that, authorize or prescribe, then give the medication, see that the patient takes the medication, follow the patient by any chance any adverse event is there, then identify in case of adverse event associated with the antimicrobial agent, stop, then like reassess the treatment options and give the correct antimicrobial agents to patients. These are all the ASPs with respect to the meropenem. So thank you very much, Pfizer, for giving me this opportunity to give the best understanding what I have done on the antimicrobial stewardship program, all my experiences while prescribing the antimicrobial agents, following the treatment guidelines, and monitoring the patients, especially antimicrobial adverse events, and trying to tailor the prescriptions, tailor the dosings. So that's all what I have learned, what I have practiced. That's all I have shared with you. Thank you very much, Spirant, for giving me this opportunity. Thank you all.
Thank you. Thank you, Dr. Adepu. That was a wonderful session, on, especially when we talk about ESP and India becoming the hub of superbugs and everything. We getting lots of news in the social media as well as the print media. So I am sure these kind of programs will go a long way in improving the antibiotic practices. And we've got lots of queries from the audience, Dr. Adepu. We might not be able to take all of them, but I'm just taking a few of them. So one of the questions that one of the audience has put up is, what exactly do we mean by reauthorization of prescription? So what does that entail?
Reauthorization is, say, generally antimicrobial agents are prescribed in the ward or maybe in the primary care setting, whatever it is. Say the prescriptions need to be authorized by the or signed by the prescriber. It's not that just simply writing a medication and giving the prescription is not, we cannot consider it as an authorized prescription. So better to sign, and then in case of the hospital, better the PG or an intern should authorize that yes, it is being prescribed and the medication need to be procured. The same thing can be passed on to the nurse, and she will get it filled from the pharmacy, and then it can be dispensed or it can be administered to the patient.
And I'm sure from you have mentioned it a couple of times also that there are huge difference of practices, the pharmacy practices in the developed and the developing countries. So, what do you think are some of the steps that pharmacists in India can do in a very simple way, which will help in improving the resistance patterns, which maybe are not being done till now?
Yeah, there is a huge scope of pharmacists coming into the healthcare system, especially providing the care directly to the patients. For example, patient counseling. Patient counseling, a very important note, where the appropriate information for the safe use of medications for the patient can be passed on by the pharmacist, because the medication usage information is known to the pharmacists because they learn a lot about
Absolutely.
the pharmacology. So it is very simple way starting with that activity, followed by now they can also have the clarity of the rationalization of the prescription, because when medications are given, the medications by any chance any underdose, overdose, what we call them as the drug-related problems. There are 8 categories of the drug-related problems, like underdose, overdose, drug needed, but there is no drug, and there is a drug, there is no clinical condition, and the drug-drug interactions, adverse drug reactions, availability of the medication. These are all the different categories of the drug-related issues, which a pharmacist can apply the knowledge at the bedside when the prescription is given and advocate, or rather discuss with the clinician in the best interest of the patient. It can be accepted because this kind of the clinical pharmacy practice is happening some of the best hospitals, especially in South India, even in Apollo hospitals, in even in Mumbai. I have seen so many hospitals, they are having their clinical pharmacists working along with the doctors. And even in oncology, their role is very much appreciated. It is being used in the Aditya Birla Memorial Hospital. So now the concept of this clinical pharmacy practice is begin. And as I said, to start with the counseling, to analyze the prescription for drug-related issues, and monitor the medications for the adverse drug reactions. You can, in case if the patient is not comfortable with one medication, instead of simply stopping that, understand why it is. Then if it is really causing a concern, next time unknowingly another prescriber gives, it is going to be a big challenge to the patient. Even sometimes it is a life threatening. So that can be avoided. So that is the best opportunity the pharmacist is getting. And drug-drug interactions, because now if you see, most of the prescriptions are like a drug menus. So it is not that giving medication, whether the medication is really needed or not, as per the clinical situation, because I myself used to dissect that kind of the prescriptions and used to have a discussion with the consultants, and then they say, yes, it is really addressed, and the changes which are in the interest of the patient used to happen. In that way, we are helping the patients. So that is, our knowledge must be towards the focusing on society health. So in that way, if it is being used, you are appreciated. So pharmacists, they have a lot of scope to do.
No, completely agree, Dr. Adepu. This has to be a multidisciplinary initiative and
Exactly.
cannot be just initiated by one person or one team. So that also brings us to a very relevant question that one of the audience has put up. What he is asking is that you mentioned that some very good pharmacy practices are happening in some state-of-the-art hospitals. But what about the middle-level nursing homes where they do not have huge teams, they do not get antibiotic resistance patterns also? So what do they do? How can their setups?
See, they do appoint pharmacists in their hospitals. I know that. Yeah, everybody will
Yeah,
agree.
they do.
They do appoint the hospital. They do appoint pharmacists for their pharmacies. Correct. Now appoint the pharmacists. Not only pharmacists, better appoint clinical pharmacists who can be a bridge between your wards and to the pharmacy. So there, what happens? You are bridging so many issues. Like if the hospital authorities, they feel that, yeah, the paramount is the patient care, just by investing little extra amount on this kind of the practices, many challenges can be avoided. And the other side, clinical pharmacists also come into the limelight, and they contribute a lot to the societal health.
So I think everybody has to adapt as per their situation. We cannot fit one solution for all the setups.
Yeah.
So that has to be taken care.
I have one experience. Just I wanted to share it with you because it is open platform. People may be listening from different parts. So I had an experience. Like I was as an academic fellow undergone training in the University of North Carolina Hospital. It is only 350 bedded hospital. It is a state funded hospital for their training of the medical school students. They have 35 clinical pharmacists. I was surprised. How do you manage 35 clinical pharmacists? For 10 patients, one clinical pharmacist. It's a huge money that you are going to pay them as a salaries. Then the director, he told me the answer is, every dollar they are spending on the salary, they are in fact recovering $20 saving on the medication costs. So huge saving. Then when the huge saving is there, they don't care in spending on the appointing clinical pharmacists.
Yeah, basically, I think it's more of a thought process that you have to develop. So a similar question again, Dr. Adepu, is I think many of these pharmacists face the same problem. So what they're asking is, okay, he's working as a clinical pharmacist in one of the institutes, but they do not have any data analyst or a team which is set up for ASP. What would your recommendation be for such setups? What kind of core team do they need? So
yeah, I do agree. The challenges what we are facing, not that first point is many hospitals are not having clinical pharmacists. Second point is many of them are, those who are having are not properly trained. Now the opportunity or the responsibility lies on the hospital to get them trained, because the training means they are adding knowledge to their employees. So that knowledge being reused back on their patients. So obviously the organization is benefiting. So that is the only way we can adopt the technique of improving the knowledge and skills of the practicing pharmacists there. So that is the only way. Otherwise, yeah, like the Pfizer coming out with many programs and helping these people to develop their skills, because in a way, once again, it is a social contribution as a corporate social responsibility, adding value to the practitioners, and in turn these practitioners add value to the health of the society. So in that way it can be achieved.
So, what do you do, Dr. Adepu? How do you suggest that when a pharmacist receives a prescription and he sees some error in that, it might be in terms of maybe the wrong dosage that is being given. Duration is still subjective. That might be the doctor might be liking to continue it, but if there is a wrong dosage or even the frequency, how do you suggest should the pharmacist interact with the doctor?
It's a very, very
challenging
situation. Honestly, very challenging situation because many times, clinicians will be under the impression that, yeah, this is the best thing what I am giving.
Absolutely.
And as a pharmacist, somebody commenting on their prescription, it is as good as they feel that they are challenging their knowledge and skill. But the major point, whether it is a doctor, whether it is a pharmacist, whether it is a nurse or any healthcare professional, we are all there only for patients. So if the patient care is a paramount, if we keep aside our individual prioritizations, then there will not be any problem. Once again, here, it is how politely you convey the message matters. Yeah, doctor is a doctor. Always I have that respect. But at the same time, I understand there is a small error in prescription. It's a wrong dose. For example, dose adjustments. I have experienced this kind of these challenges. Means dose adjustments, which I used to outrightly do, and fortunately, my consultants were very close to me, and they said, "Okay, you change, you write the prescription, no problem." So that kind of rapport we used to have. So initially, what I used to do is I used to convey the message, doctor, this is what I have observed. Probably you are right, but as per the literature, this is what it sounds to me. Maybe I'm wrong, but just I wanted to put it to you so that you can take a right decision. Just what you want me to do. Yeah, some doctors used to be, oh, is it? Then they will go through it and then they'll say, yeah, you're right. Okay, fine, let's change it. And they'll make a change and they'll give the prescription back to me. Yeah, it is done. Some people, they say, no, I know what I have to do is please don't bother about it. You continue. Okay, fine. Then ultimately when the patient gets a problem, then who is going to face the problem? It's not me. Absolutely. Right? Because that kind of a challenge also I experienced. And then the senior consultant used to ask me, then what you are doing there? Then I used to say, this is what I conveyed.
Okay. I'm sure with these so many programs running, the doctors are also getting sensitized towards such concepts. Where pharmacists do come back and point out that there, and at the end of the day, I'm sure doctors are also humans. So they are likely.
Error is human. We have to accept error is human.
Absolutely.
Very clear. See, in New England Journal of Medicine, they clearly say that error is human. Yeah, accept it. Only thing is, how do we put it across in the interest of the patient? Yes, that's what matters.
Right, exactly. So we have many more questions, but I think due to shortage of time, we'll be taking this last question, Dr. Adepu. This is a little bit different from what the topic we have. Not different, but this is from a person who's asking, like at a retail pharmacy level, where they do not even get much time and to educate the patient. What are the few things you would suggest that they can do?
This is once again a very interesting thing, because retail pharmacies, the challenge is patient will not stay there for a long time because they are in demand of the medicines. The most focus is filling the prescription. But along with the filling of the prescription, quickly information passing on to them, it is one strategy, so that you are passing on the correct information for the safe use of the medication is being done. The second, in case if there are errors, it's always prudent to never talk anything to the patient. Based on your report, if you have that report with the prescriber, then you can politely convey, sir, this is what I have observed. So what do you want me to do? Or you want to just continue the same? Leave that decision to them, because it is not a situation unlike in US. In US, there is always a prescription audit. If there is an error and if you don't tell that error, then you are at fault. Correct. Here, that kind of situation is not there. So you have to go along with the situation, convince the consultant or the prescriber, respect them, then convey the issue in a very polite way that it does not hurt their feelings. Then they also feel that, okay, here is the fellow who is also doing something productive, but in the interest of the healthcare system. Yeah, let me respect his work. Then, yeah, individually, when they understand each other, then it is going to become successful.
So with this, we come to the end of this very, very informative and interactive session. And a big vote of thanks to Dr. Ramesh Adepu for sparing his valuable time and giving us an insight on this very, very good topic. I would also like to extend my thanks to our educational partners, Pfizer, and our CME partner, Spirent. Hope you all had a very good session. A great weekend to all of you, and thanks once again.